Now we're going to dig into narrow irregular tachycardias. And what rhythms could that be? Well, atrial fib should come to your mind because atrial fib and atrial fib and atrial fib, that's the most common narrow irregular tachycardic rhythm that you're going to run into. What else could it be? Well, I guess it could be something like the sinus tach that's got a bunch of PACs, or maybe even a sinus tach that's got 3 or more different foci firing, which would be meet the definition of multifocal atrial tachycardia, MAT. Remember that wandering atrial pacemaker, once it exceeds a rate of 100, is called MAT. And so wandering atrial pacemaker, again, being where there's 3 or more ectopic atrial foci that are firing. So that's possible. It's not all that common. In the back of your head, in the back of your mind, you should say, well, it's irregularly irregular, and so are there P waves? And if there are P waves, then it's not atrial fib, so then it would have to be sinus tach with a bunch of PACs, and maybe enough to actually trigger the definition of multifocal atrial tachycardia. But most of the time it's atrial fib. Atrial fib. If atrial fib is unstable, if any narrow irregular tachycardia is unstable, we're going to synchronize CardioVert at 120 joules. Sometimes that will work. It tends to be the sicker they are, the less likely it will work. So it may be that you have an unstable patient, doesn't respond to your cardioversion, and so we always talk about cardioversion for unstable, and we never go any further because we act like that's always going to work. And if it doesn't work, then you're going to have to add some pharmacology to this as well. And so that's going to be off protocol, and that's going to be outside standing orders in almost every case. And so that may be somewhere that is a situation where you would want to contact medical control ASAP and explain what you've got. I have an unstable patient with a narrow irregular tachycardia that failed to respond to cardioversion. I guess I need to move on to medications. What do you suggest? And so you may have to make that case. So next point here is we're talking about narrow irregular tachycardias that are creating symptoms but are not unstable yet. And so it could be that, very much like sinus tach, that this is just compensatory. And so it could be that, the patient lives in atrial fib, has for years, hope they will for years more, and when they're shocky or hypoxic or upset or angry or have been exposed to some kind of stimulants, their heart rate's going to go up. So let's make sure, as best we can, that the atrial fib with a rapid ventricular response is actually the problem, and it's not a response or an attempt to compensate. But be aware that A-FIB with a very rapid ventricular response can cause or lead to cardiogenic shock and CHF. So is the problem the rate, or is the rate a response to something else? It's an important question. Potentially your history, present illness, and past history may help you there. Remember that critically ill patients can have new onset A-FIB, so just because a patient doesn't have a history of it or says, no, I do not have a history of atrial fib, well, they could be an atrial fib right now. So contacting medical control is a sign of a smart medic, not a weak medic. When things are outside the usual, outside the norm, then get somebody else on the phone where you can talk to them and let's collaborate and consult. But generally, if the rate is the problem, then we're going to control the rate rather than try to get them out of A-FIB. Remember, they've been in A-FIB for years in many cases. And so it's not the A-FIB that's bothering us, it's the rapid ventricular response that is. Vagals may help, but don't really count on them. Again, all they're doing is slowing traffic through the AV node, which may be all that we need. So it's worth a try. Adenosine is not indicated, and as I mentioned in a previous lesson, if you mess up and don't see that the rhythm is irregular and therefore cannot be SVT, if you made that mistake, it's possible that you can still get some benefit by watching what happened. I wouldn't try this as a diagnostic tool, but it's happened to me, and I was able to see that, oh yeah, the rate slowed down. I was like, oh, So that clearly is atrial fib. I should not have given adenosine, and I'm not going to do that anymore, and I move on to what's right. So what is right? Vagal maneuvers may work. Diltiazem is usually the first choice in field providers. Beta blockers may work if you have one. An esmolol or a metoprolol possibly. And amio should work. It takes forever to give it, takes forever for it to work, but it may be in the list of things that are in your treatment. And what about MAT? What about this sinus tac with a bunch of PACs? Same stuff. Seems kind of unlikely that it's going to be the rhythm that is the problem, but the same stuff would potentially work, and same things you can try, and so that would be where you would go.